holding the position of RBI Chair at the Center for Development Studies before taking over as the Director of the agency. He was a Fulbright Fellow at Harvard Center for Population and Development Studies and a visiting professor at the Unit of International Health at the University of Montreal. His latest book is Shaping India, Economic Change in Historical Perspective. So, Narayana, the floor is yours.
Good afternoon. The last presenter, there are both advantages and disadvantages. The disadvantage is that the floor becomes thinner and also patience runs low because we had a long day. The advantage is that the previous presenters, like today, they are all, top people in the field. Then there is a lot of things you don't have to do. You can actually take from there. So that's the advantage. So let me piggyback on that advantage and maybe crack a few jobs so that your interest is somehow alive. I don't know how far I've succeeded in that. I think presentation is a great help because it gives me a good starting point. The point that is made, very often the analysis, experiences elsewhere, they can be of great help in understanding our situation. Also the behavior of the sector, the states, or existing mix or current status, trying to understand that will throw light on some of the underlying factors. Now, that's the sort of effort that I'm going to take. And I'm going to make basically two very simple points. I'll focus on just two simple points. Basically two things. So I come here in the system to a little bit of time on the public health, because that's what you started off in the morning. The importance of that, and quite a lot of things that we have been talking all through the day, how it's simply not sustainable unless we really address the public health issue, the larger public health issue. And there, what I try to do is also draw from the experience of Canada, the recent past. And when a state like Kerala doesn't address that issue, how it comes into a sort of unsustainable sort of a system. That's the first sort of a point I like to make. Then I will turn to the issue of human resources, the inequalities in human resources. So often we neglect this because even a state like Kerala, with a surplus, human resource sort of a thing, how you can have a number of districts where vacancies of medical officers can run into 25-30% of the required positions. And then, what are the sort of underlying factors? Is there a way out of that? That's what I'm going to focus on. So the first point that I'm trying to, I'm going to make is access to health. Is it access to health or is it access to health care that one is talking about? The two are different. And if it is access to health, then it needs to be placed within the larger frame of social determinants. That's the point that made in the morning. I do not have to elaborate it because in the morning we, Imran elaborated in great deal and Amit also mentioned about that. And when I talk about social determinants, in particular, I am focusing on the public health dimension. Now, we simply seem to miss this out. And any model of health, missing out of public health, can become extremely costly and unsustainable. Okay, so this I just covered. Now, public health alarm, I just don't want to go into any great detail because it's already discussed in the morning. Yeah, but the definition often given is an idea. Now, public health is organized only to a limited extent. That's because it has a very narrow base in many societies. And that base is often captured by medical doctors. And in fact, the conflict which Imran was talking about in the morning, the clinical practice versus the public health sort of a thing. You know, the problem is that not the problem of the conflict itself, it's who is more powerful. There is a public issue. And it's the clinicians who often capture the space. And we have hundreds of examples of that. And the way it's often done is that, you know, a clinical success, just look at the media coverage, it's glamorized. And then, you know, they become, you know, this also, there are various ways. So once they capture, then public health just simply doesn't have that much of a space. So when we talk about the organized response, now who captures that organization, that becomes very, very important. And also public health, by this very definition, it is a summation of the working of several institutions. And since it is a summation of several institutions, it's basically a political process. And to be effective, deliberative political culture is needed. Do we really have that? That's the sort of a question which becomes a topmost sort of a question. Now here, drawing from the example of or experience of Canada could be quite useful. Now what they did, you know, 10 years ago, when they were hit by the SARS, that renewal of the public health, it was a response to SARS in 2003. You know, 10 years is a long time, so you must have forgotten about it. SARS first heard in February 2003 in China and reached Toronto in Canada in the same month. And there's a patient who died in March, and by March end, 19 cases were reported in Canada. But it was quickly contained. And how did they contain it? Basically, old-fashioned public health measures. Washing hands, using soap, and all of those. Nothing new, no rocket science, or only that. And containment of SARS showed the power of public health. But they didn't stop at that. Very quickly, that's a response of the society, that's what's important. They took it as first emerging infectious disease of 21st century, and the Canadian society has to respond to it. So they went back and they thought they should have a critical look at its public health system, their public health system. And two committees and a working group were constituted. You probably must have heard of the Naylor Committee, and they recommended creation of a federal public health agency, the PHA, and recommended appointment of a chief public health officer. And a standing Senate committee agreed to it. So all it happened in very quick succession, in about 4-5 months' time. Committee submits the thing, a working group, and then decisions were taken. And the working group emphasized the need for a clear and solid legislative foundation for the agency. It's not enough just to say some public health agency, but a solid legislative foundation so that they can carry out their task effectively. That was the response of Canada to SARS. SARS first it was contained, but old-fashioned public health initiatives. Then the society responded to it. And the Public Health Agency was created in September 2004. Within 1 year, you would have it, the Public Health Agency was created. And a chief public health officer was appointed around the same time. And of course, this first annual report brought out in June 2008. Because the CPHO, it's not an governmental position. They are mandated to do a whole lot of those things. Each year they are supposed to bring out a report, which then goes to the parliament and things of that sort. Now, the annual report is intended to inform Canadians and stimulate dialogue the many factors that contribute to good health and what can be done individually and collectively to advance public health in Canada. Right? Quoting from the report. Now, and the focus of the first report was on health inequality. Again, the next quotation, I think it's very important for all of us to remember that. Now, the question they asked is, why is it that although we are on average the healthiest we have ever been, many in Canada have not shared in that health and well-being? That's the question they asked. Pure inequality sort of question. How is it that, health-wise, Canadians are on top, but still there are sizable number of populations in different regions who are not able to partake with good health. But that was their concern. The people at the bottom rung. Now, that I would call as inclusion. Have we heard anything similar in India? Even when we talk about all these UHCs, anything of this sort, have we heard? At least I have not heard, maybe I have not read too much of this. And even for a state like Kerala, I haven't seen anything of that sort. And because we don't do that, we pay heavy price. Again, I want to bring up the Kerala experience. It's well known for, like today morning, I think, till now we must have heard Kerala, I don't know how many times. But I have a slightly different view on the Kerala sort of picture. Now, if you look at the reality of the last few years, almost any disease which is reported anywhere in India is being reported in Kerala. Chikungunya, dengue, even Japanese encephalitis, all are being reported in Kerala. And dengue, in fact, Kerala probably has the distinction of reporting dengue in all the 14 districts, all through the year. I don't think any other state in India has that distinction. That's what Kerala has done. I think last year, and also increasing traffic accidents. 5,000 deaths every year on the roads, and it's only increasing. And of course, lifestyle diseases. And it has a large healthcare sector and rising cost of care. Now, how is Kerala facing this challenge? Very good. Look at it's all from published figures. Now look at the share of Kerala in the dengue case. For a population, our Kerala's share in the Indian population is less than about 3%. But we account for about 8 to 9% of the dengue cases. And case fatality rates are also not very low. In fact, of course, it's lower than Tamil Nadu, but Tamil Nadu, in fact, is often credited with making wonders in public health and a whole lot of those things. But when I looked at the case fatality rate in dengue, they are not doing all that well. So obviously, something is not quite right. Also, look at even Tamil Nadu's share in the dengue cases. Now, obviously, something is amiss. That's because we are not really focusing on public health awareness. Again, look at the diarrheal cases or enteric fever cases or the TB cases. It doesn't look all that great when you look at these numbers. Of course, these are not updated to the old table, but if you update it for all the recent years, it doesn't look very different. And I should look at the numbers. And it doesn't instill much confidence that Kerala is doing all that well. That's why it's doing good. And all these cannot be addressed with the healthcare sector. These are public health issues. And there is absolutely no consensus. And consequently, what happens is that, you are in a system where, there's a surplus of doctors, medical doctors. So more than one medical doctor per 1,500 population. Even the smallest village have one or two alloptic doctors and a PhD and maybe a private nursing home. And about 10% of the population sleeps in the hospital at least for a day in a year. And that's what we have come to. an allopathic doctor is within 5 kilometer radius. Large number of Ayurvedic and homeopathic doctors all over Kerala. Fortunately, we don't have too many quacks. But I hope you are listening. And about 20% of the population consults a doctor during a month. And the burden of healthcare goes very high for Kerala because we also have a very large private healthcare sector. Now, if only we had focused more on public health, like communicable disease, traffic accidents, lifestyle diseases, things would have been. That's my point. About the public health, how we, when we miss that out, what happens is it's going to be a very, very costly problem. And it's not, definitely not going to be sustainable. And then what does the government do? Now you have to need, of course, health insurance is the top. So Kerala has implemented RSBY in all the 14 districts from 2008 onwards. And we have one of the highest enrollment rates, also one of the highest utilization rates. So whichever insurance company takes it up, they end up making losses. But then of course, Tamasha goes on because they compensate it with other sorts of things. Last 4 years it was United India Insurance Company. Every year starting from year 1, claims ratio was more than 100%. But this year it is Reliance General Insurance. They have, because I was talking to the health secretary, I said, why did they come? Now he said their strategy is very simple because now it's the next 3 years, whoever has come is going to be there for the next 3 years. And they have a fairly good IT infrastructure. They're going to build up this entire thing, and then it will be very difficult to displace them. Of course, the premium will go up in the next round. So that will be their strategy. Yeah. In addition to that, 2 years ago, the finance minister introduced what is called a Karunya benevolent fee. Because as you know, RSBY doesn't cover a whole lot of tertiary care sort of a thing. So the minister comes up with a very popular Karunya benevolent fee. Again, this is the political sort of dimension of it. You have a running RSBY thing with a fairly good setup. You have a way of assessing the surgical rates, fixing it and all that. Then you introduce something like Karunya scheme, where it's a slightly different sort of procedure altogether. Because you don't have a package rate or anything, you can get maximum up to 2 lakhs. You can access private care, you can access the public hospital, you can access almost anything of that sort. And then every 15 days, 20 days, you see this advertisement coming out in the newspaper with the finance minister walking tall saying that we have given away so much money. And in fact, the sad story is that what has been disbursed under the Karunya benevolent scheme over the last 2 years is over 150 crores. Whereas the money they have spent under RSBY, because RSBY 75% of the premium is paid by the center, only 25% has to be paid by the state, is I think half of what they have disbursed under the Karunya benevolent scheme. So this is the sort of the thing that happens. But my question is, can insurance or this Karunya sort of fee solve the problem that I highlighted earlier? It would in fact increase the burden collectively, because insurance basically pools the risks and redistributes the burden. It does not address the underlying factors, and that is the public health challenge. So one has simply no way escape from that. Yeah, with that, the first point about the public health thing, I think I have, I hope it's clear that how the Canadians handle it, and in a state like Kerala, how we simply, we're not even simply opening to that thing like that. We need to address it at some point, and then this huge burden that building up. Now let me turn to a slightly different sort of problem. That is, in response to your question, when Azim was answering that, that's what I said. Now I'll turn to that. Now it's all fine to talk about how money is not a problem and USD and everything. But where are you going to get your human resource for that? Especially the inequalities in the human resource. That is the issue that I'm going to cover next. Now when we talk about access, it needs to be viewed in terms of access to facilities and personnel. Now, regional inequalities in healthcare facilities are severe despite NRHM for over 8 years. But the problem of facilities can be tackled with time-bound deployment of large resources. If you have large resources, setting up facilities is not a problem today because there are any number of turnkey operators who will come and set up facilities. But that doesn't ensure that you will have access to care because you need to populate it with the human resource. Now, that's where the major problem is the distribution of person is more difficult to handle. Why is it more difficult to handle? Of course. Now there, what I would like to do is draw from the experience of NRHM. Actually draw from their data, draw from their reports and build up a story to show that despite putting in that much money and all this big talk, how when it comes to inequality, you are in a very, very serious sort of a problem. You still face sort of there. And mind you, the National Rural Health Mission is supposed to be a health mission, but it's focusing on health care, not on health. That's again. Yeah. And how does it do it? It does it by adding over 1 lakh doctors, specialists, nurses, and their own words, they say NRHM is a revolution in human resources. It's almost entirely healthcare, but does it help provide access to healthcare? See, if it's a revolution in human resources, you probably would have solved a lot of these problems, but has it? Let us just look at shortfall as percent of required personnel. Types of like health worker, A&M and all that, doctors, specialists at PhD, lab technicians, nursing staff. This is all from the NRHM report, the latest report. You look at it, you will see, of course, these are the high focus states. I have a next slide on the non-high focus states, so that will give you a good contrast. Now, nothing unexpected here. You still have very high shortfall of doctors, of specialists, of lab technicians in state after state. This is even after 5 years of NRHM. There are of course some changes have come about, but still, as regards number of these human resource sort of personnel, that's a very serious problem. But that's why these are high focus states. Now look at the shortfall of specialists or even doctors at PhD. If you have a 60% shortfall, 57% shortfall of medical officers in PhD, what sort of a care are you going to give? That's the sort of a state we are in at least in some of the states. Now let us turn to the non-high focus states. As expected, you see that, okay, doctors at PhD is wonderful, all these non-high South Indian states. You see a lot of the second column, zeros, and 9.57 and all these. All the PhDs probably have doctors, that's what you see. And if you look at even nursing staff or a health worker, A&M and all, it looks wonderful sort of a thing. It's a fairly low percentage. So in the aggregate, the contrast between this and the previous one, that is high focus states and non-high focus states, is fairly, comes true. In the aggregate, the high focus states, still there is a huge problem of human resources. Non-high focus states, the problem is mitigated to a great extent. May not be entirely because of NRHM, because maybe historically. But this is all in the aggregate, the state level. But then, that is only part of the story. One needs to go down to the district and see, do you really get this sort of picture when you go down to the district? What you get is of course the second. Now what I did, of course, there are a number of districts where I have. There are basically 2 districts from Bihar and 2 districts from Kerala. And I just put their own, what they have is evaluation reports. And I just picked from the latest evaluation report. And I just put those numbers. And something quite striking. I hope that is clear. Let me still spend a few sort of minutes on it. These are numbers. That is Bhagalpur, the sanctioned posts of lady health visitors, 54, vacant 40. 80% vacancy. They are not able to fill. Medical officers, 74. There is some problem. I think there is some mistake there. 74 and 70 cannot be 56.49 wrong. But 74 post sanction post, 27 vacancy medical officers. And nurses, it's of course slightly better. Area, you again have 45 sanction posts, 37 vacancy. Medical officers, 121 posts, 64 vacancy. Of course, you expect this because that's why we are in a high focus case. But now you come down to Kerala. Look at Palakkad and Kasaragod. Look at number of lady health visitors. Palakkad, 25% vacancy. Kasaragod is 38%. Lady health visitors. And you look at medical officers. Palakkad, of course, is 13%. Not very bad. But look at Kasaragod, 30%. Mind you, Kasaragod is in Kerala. 30% vacancy of medical officers. And of course, specialists, it's a different sort of a story because you don't have numbers for all that sort of a thing. Also, it has something to do with the structure of the PHC and CHC. Then, even lab technicians. Look at Palakkad and Kasaragod. 39-38% vacancy. So that is the sort of it. And Kerala exports lab technicians, nurses to all over the world. And it has a surplus of doctors. And you take, of course, you take, I also have the Trivandrum figure, but I don't have it in the list. Of course, Trivandrum it's all zero, there are no vacancies, everybody is not a good thing. And this is one side of the thing. I'll just add one sentence and then, of course, leave you for some more time in this. Now, I also have the numbers for JSY, Janani Surakshya Yojana beneficiaries. Both for Bihar, some of the Bihar districts and for Kerala districts. You know what you find? Bihar, the number eligible and the number benefited almost the same. Whereas Kerala, Trivandrum, the number benefited is equal to the number eligible. In Palakkad, it is 50%. In Kasaragod, it is even lower. Now, what I fail to understand is all NRHM figures. It's all from their reports, their sort of, whatever data sheet. If Bihar has so many vacancies, how is it that in districts you get, JOs eligible and 100% getting the benefits? Yeah. And that also raises, what Rachin was saying, because you have a lot of data and all that, but the data that you get, often we start wondering what it really tells us. But more importantly, of course, let's go back to this sort of a thing. So often these aggregates can be highly misleading. They will hide a whole lot of inequality. And the inequality are very, very great. Especially when it comes to the human resource part of it. Then you have such large inequality. How are you going to achieve anything? Even if you say, okay, you are not considering the resources. No. You have the revenue, you have allocations, everything is fine. But if this is the sort of situation, how are you going to, it is. And I have not seen much thinking on this. Now, I have an answer why this is happening. That's from my, well, I not put it down, but I looked at the numbers. Now, I would, as far as medical officers is concerned, I would blame it entirely on the centralized entrance test-based admission. What has happened, because Kerala introduced it in 83. I looked at the data on admission for over 20 years period. Over 20 years, what has happened is 75% of the admissions are from 3 cities. Are they going to go back and work in any of these backward districts? No, that thing we can't expect them to work. So, That I think is the, that must be the problem elsewhere also. And it's a very, very serious problem. Now there is a solution, it's not that there is no solution. They have done it for a lower level sort of a thing. Now, see West Bengal, what they have done, this is again from the NRSM report. I quote from their recent report. West Bengal's novel system of letting the Gram Panchayat select a local woman to become a second ANM and sending them for 18-month training ensures a resident ANM in remote areas. The continuous efforts at skill development among the ASHA and systems of getting them priority admission to ANM and nursing schools will be able to secure resident health workers in remote areas. It's not that we don't have solution, but if they can apply that solution at a lower level, why is it that they cannot apply that at some other level? Now, that is the sort of a way I think we slowly will have to think. And without that, of course, even if we do that, we are not going to have a solution in the next 5 or 6 or 10 years. Because even if you do that sort of a thing, even if there is an agreement on that, people are sort of recruited to say each taluk level and send for this sort of a training. Firstly, of course, if you send 10, you can't expect all the 10 to go back and work there. But even if 2 or 3 work there, but it will take some time. It's not going to be an easy solution or an immediate solution. There is a time sort of a trajectory for that. But this is something which has to be sort of kept in mind and worked on. But there doesn't seem to be much thinking on these lines. Yeah, I think I already made that point. So thank you.
Thank you, Dr. Narayana. I think it's important that we got back to sort of the root. One is the issue of the public health, the need for a public health approach, and the issue of human resources and the training of workers and looking up at the whole range. These are crucial for universal health coverage and they're often underestimated. So maybe if we can take the question.
Just struck me. I like the comparison with Canada. I think it's very, very interesting. But it made me wonder as to why it is, and I think Azim also mentioned the same thing, that when it comes to politics, health doesn't have any kind of a club. This trade-off between employment and health that we argue very interestingly. Lead me to wonder, say, take a case of Kerala. Why is it that Panchayati Raj decentralization is a political bandwagon? Employment is a bandwagon, literacy is a bandwagon, and think of any, why in our culture is health not an equivalent bandwagon? Of course, you can't answer it immediately, but you can certainly look at the comparative history of other countries and ask the question in those countries, is there any evidence of health actually becoming something that for which there is political payoff? Because unless there is a politicized demand for better health, you can't get the government machinery to act politically. And so that sluggishness that you see is partly connected with that. So if you knew, for example, a good example of other countries, it would be good.
It's a direct example of that universal thing. I think it was if I remember right, there was this memorandum submitted to the king and all that. The king and the new government took over had to act on that sort of thing. Similarly, I think Mexico. I think came because the minister, when he went for the election, he made that promise. So when he got elected, he had to sort of take it up and all that. But having said that, this is Kerala, it's surprising that in 2006, when the current UDF came, then when they went for election, see they talked about the insurance thing. And then when they lost the election, the LDF could not wash its hands off the insurance thing. But then that's why the RSPI got implemented. But you see, it's one thing to talk about the RSPI, but the larger health issue somehow that didn't come out. That's a bit surprising because I never understood that. Especially because when the panchayats are also so active, but somehow nobody seems to take it up that way. And of course, I have feeling that one of the reasons is that I would call it a allied capture. Let me put it this way. Now, see, when we talk about data, now the example that Azim gave, NSS, NFHS, what are we doing? We are basing our inferences on the basis of this highly centralized data collection mechanism. Now, don't we have, if you look at the history of public health in Britain or in Europe, how did it start? It didn't start with data collection at the macro level. It's at the community level. That the doctors, whole lot of activists collecting data on mortality, and that's how it got started. And relating it to disease, correct me if I'm wrong. Whereas now we have a legislation on civil registration of births and deaths. But has anybody tried to use that data? Or has anybody tried to get that data? I'm asking this question because I tried in Kerala a few years ago, 3 years ago, because they go around claiming that there is 100% civil registration. And there is a body which does which is the repository of the data. So I approached them saying that why don't you give me the data for at least a few districts so that I can sensitize at least some of these medical doctors in some of those panchayats so that they take some interest, and once it starts, see, for example, that's why I gave this example of traffic accident. Now you might have a macro awareness and all that, but it is not that these 5,000 accidents or deaths take place all over the state. There are some crucial areas where it takes. Now if some of those panchayats and municipalities are sensitized to this issue, they take it up on themselves, then things are definitely going to change. But today, that doesn't happen because, see, none of them there, they have the information. Now what? See, this civil registration thing. There, of course, the doctors also have important role to play, that is the certification of death. If they properly certify the sort of a death, and it's put up in the panchayat notice board saying that last year so many deaths took place and these are the diseases. Obviously somebody is going to raise some question, but that stage we haven't taken it.
But I can just give you,
that it's a public health. Public health is a public good.
Exactly.
Health care is a private good.
Yes.
And people want the private good. That's what's the problem.
Yeah.
But healthcare accounts for quite a large proportion of the economy, and therefore those who in fact gain from it influence the political process quite substantially. So when the Clinton, during the election, they were trying to get the healthcare bill to be passed, but it was really the insurance companies, the HMOs and the medical professionals and the industry, which actually blocked it completely. So actually there are many conflicts of interest which are very, very powerful in health. So health is actually on the political agenda. If you look at many countries, say even in Australia and elsewhere, earlier the ministers would want, say, foreign policy foreign minister, foreign affairs minister. Nowadays even health ministry is actually considered a very important ministry. Australia has gone so far as to have a minister for mental health. They have a health minister, they also have a public health and mental health, a minister for mental health at the national level. Now in India, I think things are moving. I mean, there is this question on talking about this data, on the right to be counted among the many rights that are being fought for. The right to be counted as part of civil registration, and because in the absence of data, it's very difficult to argue a case. So the right to be counted as part of a statistical system is also one of the, I'm also part of the Janshasti Abhiyan like colleagues, and I would say that over the past, say, 12 years, there has been a voice, not only at the grassroots level, but also very much at the national level. So during the negotiations for the NRHM, there was quite a strong role played by members who were part of this body, and also related other academics and others. Yeah, I just finished this. So there's been a process where even public health professionals have played trying to push for certain things, but the vested interests are strong, and there's a question of sort of gathering of strength, not just at the national level, but at the global level, because it is all interconnected. I mean, these policies are interconnected from global to local. Yes, Indra.
I think it's a very important question that you are making. Why is it that health is not protected in India? And I think this is being on the second floor. I believe it is so because we are so stratified, so caste-ridden, which is not the case in other countries. So poverty is legitimate in this country, and health is an outcome of that. And therefore, poor being sick, poor dying is something that we are very used to. So it is very difficult for health to become that kind of a political agenda. And the kind of political agenda that health is today is what is considered quality health care, private health care. And that's why wherever you place me, I will cry public health. Because to me, health is not a private good. Healthcare is not a private good. Healthcare is a public good, because if you have a system running, that system is run by individuals, and that's what I was saying in the morning. It's not a private practitioner whose time is contestable and therefore somebody can buy it. A system has doctors running it 24 hours, and that system has no contestability. It is open to everyone. And in policy, the kind of services that we are building today, that's why today public health is such a challenge. Because in a society as distorted as ours, there's so many things that are taken for granted. Like Karwa Chauth becomes a big marketing agenda. Oh God, the way they sell gold on that day is nobody's business. So it's very easy to use our tradition of this kind, but it is very difficult to build something different and something new. And the kind of public health that I'm pleading for is something which says medical care has its limits, because health is more than just healthcare services. And I'm ready to say that I can only do health care. I cannot do health without other partners. But even in doing that health, I believe the challenge is that you define public health. We jump into supply-demand curves without defining what is the nature of services that you are talking about. Are you only talking of clinical services, of tertiary care for heart surgery, neurology, obstetrics, cesarean sections? Is that quality care? It is not, and that's the plea I'm making. And the point I would like to make is that you are saying taxation does not necessarily translate into more investment. But have you seen what is happening to taxation? Taxation itself is changing in this country, has changed in this country. Your direct taxations are going down in favor of the middle class, your indirect taxations are going down. So you are shifting the burden onto the poor. So it is the whole thing that you have to see. And I really think that if we want a dialogue between public health and health economics, then the health economists will have to place their notion of their conception of public health. Because without that, there is no yes, sir.
I totally agree with what Professor Rama said, and I was so happy this morning when you made the point for dialogue between clinical medicine and public health. But I want to go a step further and try to explain an idea that most likely you will not like that much. When you describe stratification in your society, I would add to that also a stratification which adds on to the complexity. And that is that you here in this country have a so-called public health community, you have a community medicine community, you have a clinical community, you have a corporate sector, you have all those are totally atomized. And it might, and that's more than waste, that's dangerous. So it might be good sometimes, you gave nice examples of what happens in Canada, but it might be very nice to look also at examples in the non-Anglo-Saxon world, where this was not necessarily the case, like in continental Europe. I'm from Western Europe, I'm from Belgium, where through political struggle for more than a century, people get identified with health within a political struggle and make sure that health has a high place on the agenda, that clinical medicine is seen as a part as public health, that public health is not limited to disease control. Of course, we have a context which is different than yours. I've heard you saying this morning that public health here came out of the minds of ordinary doctors. History tells me something else. It tells me that it started in around military cantonments by a British commission in the 1850s, and that even the public health people in the 1930s, still in the colonial period, pointed to the same as you this morning. Like Bradshaw in 1938, I think, he said this cleavage between the two is way too much, but you still have this cleavage. And I think you need to overcome it if you want to advance. It makes no sense to say we are the best and all the rest are wrong. There is indeed a need for dialogue, but the dialogue needs more than just the recognition of the fragmentation in society, also fragmentation even within this room.
I would like to believe that we are very fragmented, hierarchical, but I believe in the past 6 or 7 years, there has been increasing dialogue across, and the fact that we can happily disagree and have confrontation and still work together is, I think, a step in the right direction. So I'm happy that we have the Health Economics Association and a university and, various activists and professionals all sitting together and sharing their views and with differences. And hopefully this dialogue and debate will take us forward. Given the complexity of India and health being a state subject, we need to have these critical dialogues at state level. And it's very revealing that actually the commercialization and the corporatization of health and healthcare in Kerala is actually very high. So you've lost ground on something that actually the state is strong on. It's maybe
Kerala often surprises me because you don't have such large corporate hospitals.
there's lots of private.
Private, yes. No, but not a single corporate hospital. So you don't have that sort of a. So I often wonder how is it that despite all this happening, despite so many of us talking about it in so many forums, how is it that somehow this has not taken off? I just not understood that because some other states, for example, you take a state like Andhra, it's corporate hospitals now, all over. Rajiv Gandhi, Arogyasri, the amount of money that has gone into the corporate, huge. But you don't have that sort of thing in Kerala. You don't have a single corporate hospital. But none of this, no. No, that's still not a, but it's still not a corporate hospital. And Apollo and others have not entered Kerala. They have not been able to enter. Now, despite that, somehow we have not been able to, and also you have so-called some of the people's movement and things of that sort. But this public health somehow has not become a movement which it should have, especially over the last 5-6 years. All this, all the communicable diseases have appeared in Kerala and it's become a huge issue. In fact, in 2006, they had to call the Navy doctor to take care of the chikungunya. You know, that's the sort of a, but we don't seem to learn from these mistakes at all.
Gulati says it is a breakdown of the public health system completely. It's the epidemic of epidemics, as
Yes.
I think Dr. Banerjee had once talked about. And I don't know how much longer we should be wrapping up. Yeah, we should.
I would only like to say one thing, and that is just to assure you that, when one disagrees, it doesn't mean that along with disagreement, one is not learning from those one is arguing with. So I have learned a lot.
Yes, sir.
There's one thing that I showed incidents.
Yeah.
Is it due to high mortality or high reporting or better reporting?
No, I don't think it's a better reporting.
In Rajasthan, I know there are a lot of children cases, but they don't report.
It's not just the reporting. No, right now, taking cases which are reported here, I would say these are under-reporting. Because a lot of private, because we have a large network of private, not reported in the public thing. So I say, reporting we have a huge problem, like many other things. There are a lot of things which come into the private sector. Especially in cases and other cases. Those who go to the private hospitals, many of them don't get reported. It's not that sort of thing.
Maybe I'll just like to say one, if you calculate the cost of not investing in healthcare, it's another societal cost, and the cost of undernutrition and everything else is something the country cannot afford actually.
You're right, it's not India. When we had that in 2006, rubber is the issue to manage they said 400 crores was the production of rubber of that year. Because that was rubber bag was perfect.
And thank you so much. I think it's very tempting to kind of keep the discussion going. But thank you everyone to contribute this deliberation. And I think what distinctly emerging from this day-long deliberation is the need for increasing dialogue and critical engagement with this discourse on UHG. I think here the acronym serves better, so you still have not understood whether it's increasing coverage or universal health care. I'm talking about access to health or access to health care. So I think it's important as a research or academic or practicing community to be able to engage on facts and issues before we claim to achieve USC by 2020, 2025 or whatever. But we are privileged to have Dr. Premji, who is the CEO of Azim Foundation, with us. Wherever you are coming.
So wish you all a very good evening. And at the outset, sincere thanks for being here for the day. One of the difficulties in some of these valedictories that start after 5:40 or so is that you end up in talking to yourself. Or with the person who is waiting to collect his carpet on which you are sitting. Long ago I learned that the number of people in the room is not necessarily the indication of the quality that happens in the room. And this was about some 7-8 years ago. I had gone to IISc, Indian Institute of Science. And I was not fully aware of what the audience, the kind of audience that I'll be really interacting with. So there was just about 23 people. It's a large room. And I was introduced to some of those people as I was entering, and I realized 7 of them were Nobel laureates. This is what IISc does because they have wonderful contacts across the world. And this was a very high quality science kind of forum. And of course, this created enormous lack of confidence in me in talking to them. What can you talk to these people? I don't have much expertise in health per se, or for that matter in anything.
I have some notions and ideas about education, and as a foundation, long ago when we started discussion about starting some initiative like this, 96, 97, 98, final shortlist was of these 4-5 issues: health, nutrition, education, poverty, and finally we decided to be in education. But after a journey in education for about almost 12 to 14 years, we are not able to segregate, we are not able to separate issues such as health, governance, nutrition, education, livelihood, because they are so strongly interlinked at the ground level that we are not able to segregate that even in the academic institution like Azim Premji University. Sure, there are courses and there are people assigned to those courses and things like that. But the reason we are fighting very strongly as a university for not creating silos and not creating departments is precisely this. That when you, after all, the birth of this organization was from the ground level. And at the ground level, you see things are so intricately interlinked that you cannot deal with them looking at them as separate issues. And I was just listening to Madam here, and there were so many important issues I'm sure that you must have deliberated during the day. I actually recently went to a government institution, a public institution as you would say, public health institution. I suddenly was diagnosed as having some sugar. I have a lot of colleagues, sugar colleagues here, and I didn't know where to go. What is the reliable place? Which is the reliable doctor? And one experience one has had during the past about 10 to 11 years, or maybe a little longer, is that all hospitals, private or public, are equally good or equally bad. What matters is how you are connected with some individuals in that institution. That determines the kind of attention and kind of care you get. So I was speaking to a colleague of mine in another organization. He said, why don't you go to Karnataka Institute of Dermatology? And he said, it's a government institution. It shares its premises with, what is that? Jaideva Institute. And Jaideva Institute itself is a beautiful institute. So with some preparation in mind, I went next morning 9 o'clock. And he actually did a good thing. I was speaking to the director who had just arrived from Greece or somewhere, receiving some reward, Dr. Sethi. And so I went at 9 o'clock, and it's a very bright, well-illuminated reception, and people in whites. And there are several people receiving people, making them sit, asking them names, asking them who do you want to meet. And I was really surprised. Because I have never been to a public institution, except for some police case that happened with my son, and I had gone to Boring Hospital. And the first thing that doctor did, actually was a trainee doctor, he started stitching him lips. He says, if you don't stitch, and my son objected, who was a fairly grown-up person. And he objected. He said that if you are the doctor and you understand what is to be done, then you decide what you do. So, and good we didn't, because he said you will have a lifelong scar, and the wound won't actually heal in just about 5 to 6 days time. So I went here with similar notions in my mind, and this was better than any other private hospital, the elite private hospitals. The doctor actually, the director came about 10-15 minutes later. He had left a message, and the process began. They started taking, file was created, they started the regular rounds of examination. And suddenly the director, who had not met earlier, he came and he stood from behind. He says, so you are in good hands, so I will meet you later. As of now, I have been to the institute now for almost about 20 times so far. As of now, I have never seen the director in his own office. I have not seen his office. He is always sitting in the reception, or he is talking to some patient, or he is talking, so that's his character, and he is always outside. The staff is so warm in terms of their basic reception. The equipment is top class, the cleanliness is superb, the toilets don't stink, and things like that. Now this institute actually was celebrated by the Chief Minister. This was about 7-8 months ago. I was invited, and I happened to land on the stage, and I was also requested to speak. So I said, very good, etc., etc. I narrated my experience in the institution. And I said, since the chief minister is there, since the health minister is there, I would say that there is a need for similar institution in every cluster or every block at least. There are 202 blocks in the state of Karnataka. There are close to 6,000 blocks across the country, or 7,000 blocks. And you need to have similar kind of, then only you have done something. And I was glad to see people talking about a system. This has been my dialogue with Professor Parshuraman of TISS. And in TISS, I am from TISS, I have not done social sciences, but I have done personal management and disability relations. And this has been my experience with the TISS social sciences side. They have very nice fieldwork. One of the best things about TISS is the fieldwork. Because almost 40% of your total time, more than 40%, you spend in the field, both for personal management and social sciences. However, the fieldwork in social sciences is primarily focused on case studies, primarily focused on institutions. So you land up in Chembur Beggar Home, Manpur Destitute Home, and things like that. Or you work with JJ Hospital, or you work with X case, Y case. So I have been actually raising an issue with him, and that they have addressed actually in some manner, that they have started a health management course. And that's a wonderful thing to happen. And my friend Amarji about, how do you manage a large system? And the several issues that the previous speaker actually presented. How do you manage a system in a state? How do you manage, my another friend Amarjit Singh, who is now in education but earlier the Principal Secretary Education in Gujarat, and boasts rightly about improving the IMR in Gujarat in a significant way. He also talks about the system. So it took about at least 6 to 7 years for Amarjit Sinha to convince NRHM to recruit people from Tata Institute of Social Sciences as people who understand in a professional manner a system of health management. And you require more and more, just as in education we say, why did we start Azim University? One of the major strong drivers is that how do you release more and more education professionals in the system who have a certain social perspective of health, management, or education, or whatever it is. Social perspective, absolutely important. Because the main issue in health, as Madam said, is actually equity. Like in all development issues, the primary issue is equity. How is it that almost 80% plus people in this country go without even a proper primary health care? How is it that more than 78% women in this country deliver not in the clinic but at home or in similar place? And these are issues. And whereas you have at one time, on one hand, you have examples of extremely elite kind of healthcare systems and institutions taking anything is available for the rich. You can buy any kind of healthcare in India today because people who are trained abroad, the equipment is there, everything is there. I visited a dentist and he says that India is far ahead of many others. You have the education, you have the equipment, you have the systems. Everything that is possible in UK and US we can do here. There will be some exceptions. And on the other hand, 80% plus people don't have access to even a reasonably good healthcare. So, isn't it an equity-based thing? And the whole thinking about providing services in this area is once again, like in education, like in many other development areas, it is guided by urban elite thinking. People who are at the ground level, who actually need to analyze why is it that the 23,000 plus primary health centers in this country, which were started with so much of fanfare, why is it that 70% of them are defunct? The infrastructure is there, the equipment is there, doctors have been appointed, nurses are there. However, the doctors do the same practice at their home and people end up in paying them. Why is it so? So we require top class analysis of this, and I think academicians, ground level people, all of them need to come together, analyze these, and guide the government. The tragedy is that we have no dearth of intent. All policies, all schemes are rolled out with great fanfare. However, it is the execution, it is the commitment to basic equity that really matters, and therefore almost all schemes actually go down the drain. And we continue to be what we are in terms of continuously sliding indices in all development indicators. So Human Development Index in 2000 was 127, today it is 134. And a lot of my friends say that that is because Azim Premji Foundation was started there. So the issue is that how do we actually account for this? How do we account deterioration in gender ratios, deterioration in water indices, water table going up? How do we actually account for all this? Why is it that there is no continuous tracking and development on each one of these? So health is obviously no. So government, I completely agree that the only system that can take care of all is public system. So we have to stress and we have to pressurize the government in providing that health care of a certain high quality to all, either through their own outlets or through a very sound insurance program that does not provide scope for corruption. Because it's a big racket, you know it. In the US also it's a big racket. What can normally cost $1 finally costs the government about $6. And it's a racket. And it is not so much of corruption, but it is that the greed. Everyone wants to make money because the money is available. And the reality is that today the rich people who are covered by various insurance plans, they actually get top class healthcare service at a very reasonable rate. And it is the poor who end up in paying more because they are not covered by anything. Our friend Dr. Devi Shetty, he launched a program with the help of ICICI Insurance with a great fanfare, something that was costing 1 rupee per month, 12 rupees per year. It has not worked the way it should have worked. The drivers, all these people who are actually completely uncovered today, and they don't know their entire, like you said, that there is, because of poverty there is ill health. On the other hand, because of ill health there is poverty. Both exist. Because so much of manpower we lose because of ill health that those people who are well employed, if 6 months they are out of their job because of ill health, the vicious cycle of poverty begins. And these are the real issues. And I am glad that a very small gathering of this nature actually deliberated on some relevant issues during the day. And I really thank all of you who came from outside and also from the university to deliberate on this. And I think I only wish that we have more frequent such focused kind of deliberations, leading to some kind of a direction that emerges, on which we can only advise the government and we can only guide. Thank you very much once again. Thank you.